Hello everyone and welcome to this lecture about dehydration. So the objectives for this lecture are to look at fluid distribution within the body. We're going to have a look at the causes of dehydration and the homeostatic mechanisms of fluid distribution within our bodies, the types of dehydration, nursing assessment of your patient suffering from dehydration, and we'll have a look at the treatment options. So it's impossible for humans to survive without water in our bodies, and we do hold a tight ship where water balance is concerned, thanks to some pretty amazing homeostatic mechanisms, which we will explore later. We can actually only survive a few days without water in our bodies. Now looking at this, well, this is quite a detailed image, but hopefully you can get out of this that approximately 60% of our body weight is made up of fluids. And as you can see from this image, the fluid in our body is contained in different sections. About 2/3 is made up of intracellular fluid, it says here, and then 1/3 is made up of extracellular fluid. And this is broken down into interstitial fluid and plasma. So if we take a closer look at this slide here, you can see that 2/3 of the fluids are intracellular, which are inside the tissue cells, and the 1/3 of extracellular fluid, that's broken down into two different compartments. We have 80% of that fluid lies interstitially and 20% remains within the plasma. Fluid shifts between all these compartments continuously to maintain homeostasis. The kidneys are responsible for regulating fluid and electrolyte balance within the body, and we'll talk a little bit more about that later. Now, there are various factors that can affect the amount of body water that we have. So, changes in body water happen with age, sex, and body weight. So, for example, the elderly have less water in their bodies. So, the older a person gets, the less percentage of body fluid there is. And females also have less water due to increased body fat, because fat is hydrophobic, which means that it's a water repellent. And those with more body fat or people who are obese will have less water, and that's also due to the fact that fat is hydrophobic, so it repels water. It's also important to know that babies have a higher percentage of their body weight made up of water. And that's because there's a lower proportion of fluid stored in their fat cells, and they have a larger surface area for sweat loss, so they have an increased risk of dehydration. So dehydration is when we have less water in our bodies than usual. It's more common in young children and older adults. The elderly are more susceptible because they naturally have a lower volume of fluid in their bodies. And they may also be taking medications for other comorbidities, and that can affect fluid balance as well. But looking at the other causes that you will commonly see is diarrhea and vomiting, heat stroke, no access to safe drinking water. That's not so much a problem in Australia, but certainly in third world countries. Burns as well. We lose a lot of fluid with burns, and we'll talk about that in the burns lecture. Medications, so say if someone's on diuretics, that can lead to dehydration if they're on the incorrect dose. And if we have a fever, we'll lose a lot of insensible fluid loss through having a fever. And when we work out at the gym, we sweat and lose lots of fluid that way, so it's important to rehydrate. So there's quite a lot of patient cohorts that are at risk of dehydration, As we've already said, infants and children, because they have a higher body water content, along with the higher metabolic rates and increased body surface area to mass index, this contributes to a higher turnover of fluids and solute. So they would require greater volumes of water than adults to maintain their normal fluid equilibrium. So there's also the elderly, as we've discussed, and obese patients, and females. And this is because we have a lower water content than our male counterparts. So obviously patients who are unconscious, comatose, those who have tracheostomies, swallowing difficulties, they won't be able to control their fluid intake as much as a conscious patient and one that has their own airway and can swallow well. So we need to take extra care with these patients and monitor them closely. Also, patients with chronic kidney disease and cardiovascular problems. And this patient cohort may be on diuretics, so they are at increased risk of dehydration too. So there are different levels of dehydration. Somebody who is mildly hydrated would have a fluid loss of approximately 1 to 2 litres, and they will feel thirsty. So this could be if you've had a big workout at the gym, you'll feel thirsty, you will drink more, problem fixed. However, moderate dehydration, that's when things get progressively worse and you lose 3 to 5 litres approximately. Symptoms of this would be extreme thirst, dry mucous membranes, dry skin, poor skin turgor, increased temperature, tachycardia, hypertension, and oliguria. Oliguria is markedly reduced urine output, which would be less than 400 ml in a 24-hour period. I'll just put that here, 400 ml in 24 hours, less than. Severe dehydration would indicate a fluid loss of approximately 5 to 10 litres and include the symptoms of flushed skin, severe hypertension, neurological changes. And mass dehydration is when there's been a loss of 22 to 30 litres, and this is generally fatal. So at this stage there's been no urine output, there's no neurological response, and the patient would die. Okay, now looking at the different types of dehydration, we can have isotonic dehydration, which is where there's equal sodium and fluid loss. This is the most common type of dehydration, so this would be from vomiting, diarrhea, or inadequate fluid intake. Now, hypertonic dehydration is the second most common type of dehydration, and it includes water loss and hypernatremia. Hypernatremia, which is too much sodium in the blood. So there's going to be a deficit of intracellular fluid and an expansion of extracellular fluid here. So causes of this would be sweating without fluid replacement, and osmotic diuresis, so in DKA, diabetic ketoacidosis, and diuretic drugs as well can also lead to hypertonic dehydration. Okay, and then we've got hypotonic dehydration, which is relatively uncommon. It's involved with loss of solute rather than water, so usually sodium. And this is where a patient would have hyponatremia, which is low sodium levels. And we often find with low sodium levels that the potassium levels decrease. And that can be from extreme GI fluid loss. So when we are dehydrated, there are a couple of different pathways that work to increase water in our bodies. Our bodies are simply amazing. So if they sense that there's a decrease in water and blood volume, the blood sodium concentration would be increased. So this increase in blood sodium concentration stimulates the osmoreceptors in the hypothalamus. Okay, this then does a couple of different things. Down this pathway, it will stimulate thirst, so it's going to make us feel thirsty. So when we feel thirsty, we get a drink, have some water, we increase our fluid intake, and that will increase blood volume and decrease sodium concentration. Now, the secondary pathway causes the pituitary gland to release the antidiuretic hormone, and this in turn ensures that our kidneys reabsorb any water, which will also increase our blood volume and decrease our sodium concentration. So here are some signs and symptoms that we'd experience if we're suffering from dehydration. So obviously, as discussed, we will feel thirsty. I'm sure we've all experienced this. Then we could have dry mucous membranes. Now we can have tachycardia and hypotension. And this is our body's response when we are hypotensive. The baroreceptors that are situated throughout the body actually increase our heart rate to keep our blood going around the body, so to speak, because of the decreased volume. We're going to have a decreased urine output and dark coloured urine, poor skin turgor, and sunken phonatel in infants. So going back to the dark coloured urine, it's very important to check the colour of your patient's urine when toileting them. It should be a nice, clear to light straw coloured urine and not be offensive smelling. So when it comes to assessing our patients for dehydration, you should always follow an A to E assessment when assessing your patients, because then you're using the same structure every time and it ensures that you're being thorough. So obviously we need to assess the airway. Do they have an airway? Then we need to look at the breathing. What's the respiratory rate like? Are they having problems breathing? The circulation will be one of the key findings in a patient who's suffering dehydration. So we're going to feel all the pulses. We're going to note what the heart rate is. We'll be doing the blood pressure as well. We'll be looking at the skin turgor and the temperature. Disability, we need to assess them neurologically. What is their GCS? It's really important to get a baseline because then you can see if there's any deterioration from there on. Exposure, so in infants we'd be having a look at the fontanelle. Is it sunken? That's a sign of dehydration in babies. Look at the skin. Is the dry mucous membranes as well? It's also important to do a full set of OBS. A urinalysis. So urinalysis obviously would be assessing the colour of the urine as we've discussed. But on a urine dipstick, if they're dehydrated, you would see an increase in specific gravity. So for our patients who have CKD or cardiovascular disease, it's really important to do a daily weight for them. They should have a dry weight, and then we can monitor any deviation from that. Fluid balance chart to monitor what's going in and out of your patient, and bloods if need be. And some patients with severe dehydration would need cardiac monitoring as well, and that's because of the electrolyte changes there. They can lead to cardiac arrhythmias. So treatment for dehydration, it's very simple. We would look at replacing fluids orally or IV, depending on the type and the severity of the dehydration. Really important to treat the underlying cause as well, and replace any electrolytes if necessary. So if we've got someone with severe vomiting and diarrhoea, they may also have low sodium and low potassium, and they would need those replacing as well to avoid the chance of having a fatal arrhythmia. And essential nursing care, that comes into play with everything, but especially with dehydration, we need to make sure that we are looking after our patient's skin. Their skin integrity is going to be a bit poorer, so personal hygiene is paramount. Thank you. I hope you enjoyed this lecture, and here's your references.